Ma'am, am I audible to all?
Yes, now you're audible.
Yes, ma'am. We are live. Um, Good evening and a warm welcome to all the respected faculties and delegates present over here. On behalf of Corona Remedies, I, Bhavna, would like to welcome you all in our COR Connect live webinar by AMOGS Medical Disorder Committee in association with our Honorable OBS and Gynae Society of Agra, Aligarh, Bareilly and Muradabad. So let's all bring forth our hands together and begin our session with the lightning of laughs.
Of separation expected through the urine and change from doctor. Apart from that, doctor, we are having endocrinology, some kind of.
We can't hear the prayer, Bhavna.
Audio is not there, Bhavna.
Bhavna, unmute yourself.
I have unmuted, ma'am. Am I audible?
Yes.
Okay. So, yeah, now I would like to introduce to you all our honorable masters of the ceremony who have made consistent efforts in bringing this webinar into execution. Please welcome Dr. Niharika Malhotra and Dr. Shaila Jamal. Dr. Niharika Malhotra is a very celebrated doctor of Agra who is a consultant at Rainbow IVF, chairperson of FOGSI YTP committee from 2020 to 2023, joint secretary of FOGSI in 2018, and assistant editor of journals of HRRD. Dr. Niharika Malhotra have won many awards and have contributed in 100 plus publications and national and international. I would also like to welcome Dr. Shaila Jamal, who is Associate Professor at RMRI, Bareilly. She is also menstrual health specialist and medical activist. Dr. Shaila Jamal is a founder and president of Society of Menstrual Disorders and Hygiene Management, North Zone Coordinator, National ISAR, North Zone Coordinator, YTP FOGSI, and Clinical Secretary, DNOGS, member of SFM and SMLM, and Chief Lead Breast Committee FOGSI member. Ma'am, I would like to pass on today's session to you from now, and you can proceed the session.
Thank you so much, Bhavna. And with this, I have a pleasure of hosting this session along with Dr. Niharika Malhotra, who is chairperson of Young Talent Promotion Committee of FOGSI, and would like to thank Sneha ma'am for giving us this opportunity. So as we have already sought the blessings from God, blessings are continuously being showered upon us. So we would like to now start the inaugural ceremony by inviting none other than Dr. Sneha Bhuyar ma'am. Ma'am is the chairperson of AMOGS Medical Disorder Committee. Who does not know her name? She is a celebrated doctor all over, very consistent efforts. She is diligent, she is hardworking, and we would like to request you, ma'am, to kindly introduce and invite our chief guests for today's session. And Niharika, would you like to say anything?
So good evening, everyone, and welcome to this wonderful session. So as you know, this is the Valentine's week and today is the propose day. So as doctors, we are going to propose to spread education and awareness amongst all of us, and also to propose that we'll make our women all over India healthier. So that's with this thought, let's begin today's session. Over to you, Sneha ma'am.
Thank you so much, Dr. Niharika, and thank you, Bhavna, you can stop sharing. Thank you, Dr. Shaila, for the kind introduction. A very good evening, respected Dr. Pardesi, President AMOGS, Madam Sujata Darvi, Secretary AMOGS, respected Dr. Narendra Malhotra, Sir, and Madam Jaideep Malhotra, respected Madam Hema Divakar, Dr. P.K. Shah, Sir, I'm feeling blessed and humble amidst all my mentors here. I welcome all of you for this AMOGS Medical Disorders Committee program with Agra, Aligarh, Bareilly, and Moradabad. At the same time, I welcome all the president and secretaries of Agra, Aligarh, Bareilly, and Moradabad societies. I welcome the respected faculties, Dr. P.K. Shah sir and Dr. Hema Divakar madam. All the I welcome the chief guest along with Dr. Narendra Malhotra and Dr. Jaideep Malhotra, our dear friend Dr. Archana Verma. And I'm so blessed to have all of you on one platform. I would request the AMOGS president, Dr. Rajendra Singh Pardesi sir, for his words of wisdom and wishes. And also I would request Madam Sujata Darvi to say a few words about this. Thank you so much, and over to you, sir.
Good evening, everybody. Respected chief guest, Dr. Jaideep Malhotra, Dr. Narendra Malhotra, Dr. Archana Verma, and my mentor, and biased dignitaries. I am feeling really honored to be a part of this webinar, and when 4 president of FOXI and 1 vice president, they are the part of this webinar. First, I wish to congratulate Dr. Sneha Boyar and especially Agra, Aligarh, Bareilly, Moradabad OBGYN Society for organizing such an academic feast on GDM, FGR, and SDP. Dr. Sneha Boyar is our ever active chairperson of Medical Disorder Committee. I wish every success to Dr. Sneha Boyar for her future endeavor in FOXI. With the galaxy of speakers like Dr. Hema Divakar ma'am, Dr. P.K. Shah, Dr. Sneha Boyar, I think this will be a great webinar. Wishing every success to this webinar. Thank you. Thank you so much for inviting me. Thank you.
Thank you, sir. And special thanks to you for, as a practicing obstetrician and gynecologist since last 30 years, I used to always feel that this is my passion and I should work for this subject. And thank you for giving me this opportunity. Special thanks to you. So, Madam Sujata Darvi, precious words for you.
Thank you so much, Dr. Sneha. I'm very happy to be the part of today's program as a secretary of AMOGS. AMOGS is a very vibrant organization, and with Dr. Rajendra Singh Pardesi, who is a very dynamic president. Convener of today's program, Dr. Sneha Boyar. She is AMOGS Medical Disorder Committee chairperson, and she is the one who has crafted today's program as such. And she has crafted today's program along with Agra, Aligarh, Moradabad, and Bareilly OBGYN Society. We have our today's chief guest, Dr. Jaideep Malhotra, past president of FOXI, and Dr. Archana Verma, past vice president of FOXI. Our today's speakers are also very well senior and very well experienced in their own subject. We have Dr. Hema Divakar, past president of FOXI, talking on GDM. We have Dr. P.K. Shah, again past president of FOXI, talking on IUGR. And we have Dr. Narendra Malhotra, who is going to be an expert with Dr. Sneha Boyar in her panel discussion on HDP. So all my best wishes for today's program and my best wishes to Sneha Boyar for her future endeavor in FOXI. Thank you so much for making me a part of this.
Thank you so much, madam. And it's my proud privilege to introduce our chief guest, Dr. Narendra Malhotra, Dr. Jaideep Malhotra, both of them my mentors. I won't spend much time in introducing them because it's a tough job. Name the organization and they have headed it, and they are still guiding many more like me. So I just request Naren sir and Jaideep ma'am to bless us with your precious words. Over to you, madam.
Dr. Jaideep first, ladies first.
Yes, over to madam, I said, sir. Jaideep ma'am.
Full points to you, Naren. A very good evening to all of you. It's such a great pleasure. Thank you, Sneha, for always, nudging and pushing me to be with you, and I really love it. AMOGS has been really doing a great job. So, Pardesi sir and Sujata, congratulations. for picking up, such wonderful topics, because these are some topics which are very, very close to my heart, because today we are the diabetic capital of the world. We have hypertensive disease very, very rampant in our country, and not only in our country, but also in the region. And it definitely, all these can lead to growth restrictions. So these are three very valid points which we are going to really discuss. But what is more important today is that apart from the management, what I always have been saying, because all these have great repercussions and long-term consequences on our future generations and also the mothers. So if somebody has GDM, her chances of having diabetes, full-fledged diabetes, is much, much more than any other person. So we need to, apart from managing all this, need to sensitize and make our population aware, so that they can take, corrective steps. So I really wish you great luck and wonderful academics to be exchanged with amazing speakers. Sneha, only you could have got them together. So all the best, and looking forward to hearing everyone.
Thank you so much, madam. In fact, very well said. Dr. Hema Diwakar speaking on GDM, and the PK sir speaking on fetal growth restriction with all his skills and details of ultrasonography. We are really blessed to have you, sir. And over to you, respected Dr. Narendra Malhotra. We are eager to listen to you, sir.
Good evening, ladies and gentlemen. It's a pleasure to have all the AMOGS, Agra, Muradabad, and all the societies today on a single platform in a webinar organized by Dr. Sneha. So it's really a fantastic topic. Antenatal care is what we need. And today pregnancies are, all of them are becoming high risk. And what we call as the great obstetrical syndrome. Now the great obstetrical syndrome encloses preterm, all the five: preterm, prom, premature, diabetes, growth retardation, PIH. And here we're going to discuss 2 or 3 of the great obstetrical syndrome. So this great obstetrical syndrome is the one which we all need to learn how to manage and be prepared to handle these pregnancies, especially GDM, which might come after 20 weeks suddenly. So you have to know what the DIPSI tests are and know the guidelines, and especially PIH, which can come again anytime, and especially growth retardation, which you might miss if you are not doing a serial growth charting. So serial growth charting is the only way which we can pick up growth retardation, and then the management is picked up by the color Doppler. So it's great to see my 2 best friends, Dr. Hema and Dr. PK Shah, deliberating on this, and the panel PIH. I am sorry that I will not be able to be the expert there because I have a physical meeting which I am addressing at 7. But if my address is over by then, I'll surely join in as soon as it is over. So congratulations once again, Dr. Sneha Buyar, AMOGS, Agra, all those who have joined. All the best for this webinar. May education be spread, as Niharika said. May we all propose today to spread the light of education to each and every corner of our country and of our world. All the best to you.
Thank you so much, Sehla. Sehla, can you introduce Dr. Archana Verma? Yeah. Thank you so much, sir, for your wonderful words, and thank you so much for your best wishes.
Thank you so much, sir and ma'am. And proceeding further, we have the Queen of Awareness amongst us.
Propose शेर नहीं सुनाओगे हमारे लिए?
अच्छा, सर सुनाती हूँ, आप आए एड्रेस देके फिर मैं सुनाती हूँ आपको.
एड्रेस तो दे दिया ना, अर्चना करे क्या मैंने?
Okay, so introducing Archana ma'am, and see, I'm blushing now, sir. Proposed day का नाम सुन के share and all. So can we have ma'am slide CV, please?
शैला स्लाइड मत दिखाए सी चल.
Okay, तो हमने पहले ही कहा मैम is queen of awareness, spreading so much positivity along with awareness education. She is one package who is socio-academic doctor, a medical activist in true sense, she started so many revolutions which started from north and seeped in through the entire country. So we have pleasure and honor of having Archana Verma ma'am as our chief guest for today's session. And ma'am, we are quite very much eager to listen to you.
Thank you. Thank you, first of all, to dear Sneha and all the great team of AMOGS, Dr. Rajendra Singh Pardesi, who has been like a mentor, and Dr. Sujata Dalvi, such a great person, and they always promote people. And today's 4 Foxy past presidents. So it's I'm feeling rather I am blushing, Shehla. That I will only say that my respect, so much respect to all the seniors and all the past president of Foxy. What everybody dreams is of reaching to that place, and the where these people have reached and how they have motivated. It is actually I always tell, how you inspire people and how much you inspire people is something really matters, and that is a thing which we all should take care. And one thing I also want to say, वैलेंटाइन वीक में ये फ्रेंडशिप है ना, ये बहुत अच्छी चीज है. आप देखो स्नेहा एंड निहारिका एंड अपनी शहला, ऐसे ही दोस्त होने चाहिए ना कि तुझ में रब दिखता है यार, मैं क्या करूं. तो इन्होंने मुझे इतने छोटी सी चीज को इन्होंने मुझे चीफ गेस्ट बना के बड़े बड़े लोगों के बीच में बिठा दिया. So I am feeling so happy, and definitely if we take care of our women respectfully, so taking into consideration what is actually the protocols, guidelines, taking care. Guidelines are something very, very important to make us safe from medical, legal, and to be heroine or hero in the eyes of a patient. Because when your patients are happy, they are healthy, they will make you the actual real hero, and that all we want. Because only thing, if we are doing work properly and making everybody happy, healthy and safe, it will be good. Namaste Hema madam, you are always I remember so much, everything, every word is echoes in my mind, whatever you say. I always tell, mother को बचाना है तो बिल्कुल ऐसे बचाना है, बोल तेरे पास क्या है, ऐसे ऐसे बंगला है, गाड़ी है, बोला तुम्हारे पास क्या है, हमारे पास माँ है, हे माँ. And PK Shah sir is the biggest senior person, and Naren Malhotra and Jadi Malhotra, no one can forget. They are the person who have motivated everybody. Then non-complaining, एक word है जिसने कभी life में एक word नहीं सुना होगा, complain. So they are always smiling every time, guiding, and so it is very. I'm so lucky to be present here to listen to all the great speakers, DPM and on DPM and all panel on PIH and everything, because we obstetrician always are in that mood, stress, that we want to give best, and then we should be connected. And COR Connect program of AMOGS is something which will make this updates very, very deep into the DNA and RNA of each and every obstetrician. That is much. It will be helpful. Thank you, Sneha, and again, so much best wishes to you. And because you are a real person, hard-working person, I must say, academically also, and as a friendship level also, what not. I can give many compliments to Sneha. Thank you. And Shela, you are another star with Sneha.
Thank you.
I'm so proud of you too.
Thank you so much, my dear. Thank you. Over to you, Shela.
Thank you so much, ma'am. So thank you so much to all the esteemed faculty and giving much blessings, love, and your valuable time for this session of ours. So Sneha ma'am, I would like to take your permission to start the scientific session now.
Yes,
thank
yes.
you, ma'am.
I just thank all the respected chief guests, Dr. Jaideep Malhotra, Dr. Narendra Malhotra, and Dr. Archana Verma. I thank my AMOGS president, Dr. Rajendra Singh Pardesi, AMOGS secretary, Dr. Sujata Dalvi, respected seniors and my mentors, Dr. PK Shah sir and Madam Hema Divakar. Thank you so much for giving your valuable, precious time for this program. And I thank all the faculties for joining here. And over to you, without much ado, we go ahead with the academic session. Thank you so much.
Thank you, ma'am. So our first session is on screening and management of GTM, and speaker is none other than Dr. Hema Divakar ma'am. So the chairpersons for the sessions are Dr. Pragati Agarwal. Ma'am is vibrant and brilliant secretary of Bareilly OBGYN Society. I myself am a witness to how she has worked for this society to bring more and more laurels, as well as being bringing academic excellence also to Bareilly from every nook and corner of, I must say, India. She is past treasurer of Bareilly OBGYN Society and treasurer of midterm UPCOG 2019 as well. Past clinical secretary of Bareilly OBGYN Society, hardcore academician, and she is one person who encourages all. Our next chairperson for this session is Dr. Shazia Munis. She is the beauty who is currently leading the Moradabad Obs and Gynae Society. She's consultant OBGYN. She's consultant OBGYN fertility specialist and has a wonderful practice in Moradabad. And she is an active member of Moradabad OBGYN Society. She has worked as editor for 2 years, as treasurer also, as scientific and cultural secretary also. She has won hearts of each and everyone, especially the Moradabad Society. People are loving her in and out. So the session is handed over to chairpersons, and I would like to request Pragati ma'am to kindly introduce Hema Divakar ma'am. Pragati ma'am.
I think she has left for the emergency. I think Dr. Shazia, you can go ahead.
Dr. Shazia, please.
Thank you so much, Dr. Shaila and Dr. Sneha ma'am, for giving me the opportunity to be a part of this academic feast. Dr. Hema Divakar ma'am, although she's a very renowned person, and madam is the medical director, Divakar Specialty Hospital, senior consultant OBGYN, and she's the dean of KCOG, and she has been the past president of FOXI 2013, and madam was the vice chair for FIGO PNCD committee 2015 till date. And she has been elected as chair of Well Women Healthcare at FIGO. So an advocate for delivering quality healthcare convener Manyata, and she's an opinion leader and influencer for social and legal issues relating to women's health. And she has lots of awards to her credit. And I think she has won the Women's Achiever Award 2015 FIGO and the Global Asian of the Year 2018. And she has lots of awards to her credit. This is just, I think, a concise introduction of madam, and she has pages and pages of honors to her credit. So welcome, ma'am, and we are honored to have you today here. Over to you, Dr. Hema Divakar, ma'am.
Namaste, everyone. Thank you, Shazia. And the web of the webinars, okay, brought to us strangely by Corona. Okay, who are hosting this very event, because COVID said stay apart, but it has really, really brought us together. What to speak from Maharashtra to Agra to Aligarh to Moradabad to Bareilly, all of us on the same platform. Brilliant. Thank you, Sneha, for your kind invitation. And I'm so happy to see Pardesi and Sujata, my dear friend, at the helm of affairs, and the Young Turks, Shehala and Niharika, doing such a brilliant job on leading this entire webinar. And of course, my three very beloved friends and colleagues, Archana and the Malhotras, who are so very dear to me. And Niharika, from morning, we've been bothering her with many, many. So, you know, the sentence that friend in need is a pest indeed. Fits very well to what I'm doing to all my friends all over the place all the time. So thank you so very much for your kindness, and my hello to PK as well. And we begin today's deliberation with very warm wishes for a very brilliant future for our very beloved Sneha Bhuyar, who, needless to say, has been an icon in her own merit, leaving no stone unturned to do the best in whatever she does. And that's what I really appreciate, because every ounce of the effort that you have put, Seha, would go a long, long way, because what you've done today is really for a better tomorrow. In keeping with the same spirit, GDM today and NCD tomorrow is something that is the buzz that we all have to pay attention to, because if we don't test, if we don't manage the GDMs today, we will have further an escalating tsunami of NCDs tomorrow. Because it's not like obstetricians, we are aware only of the short term. Thank God we have delivered this baby safely, and take home baby, take home mother, and all well. No, it snowballs into long-term impacts, both for the baby as a childhood obesity and early onset adulthood diabetes, and a long-term impact for the mother herself. And very specifically, since Sneha was the breast committee chairman, I want to bring to your notice that breastfeeding in this GDM women will not only decrease the chances of their obesity, but also will halve the chances of them turning into a full-blown type 2 diabetes after she finishes the pregnancy diabetes episode. So small steps which go a long way should always be remembered by all the OBGYNs. So you would see me sitting as one voice from the low middle income countries amidst many stalwarts of FIGO, when we push them to approve of the simplest way of the single step test to test and declare that this woman has hyperglycemia in pregnancy. A lot of confusion, whether it's pre-gestational diabetes, gestational diabetes, this, that, and the other. Then the group decided, well, she's pregnant. She's having hyperglycemia. Just call her hyperglycemia in pregnancy because she has high blood sugar in pregnancy, full stop. So that's what we are dealing with. And screening, diagnosis, 2 steps, several steps and all is a no-no for our country. One time the patient is available, one test you do, and you get on with managing her. So the government of India also, in keeping with the FIGO guideline and the FOXI guideline, said, guys, come on, screen everybody, whether she is 20 years or 38 years out of the IVF setup, or whether she has a family history or doesn't have a family history, she's lean or obese. If she's an Asian ethnicity, just go ahead and screen her. Universal screening of all pregnant women. We had a real uphill task even to execute this. Even as on today, half the number in overwhelming public health settings, difficult to even do a single step test, but we are getting there slowly and steadily. And when do we screen them? First is at the first visit, because she may never ever have been tested before. She may have been having high sugars for long, but your best opportunity is early pregnancy or at the booking visit, where you can recognize and lead the way forward to the management. The typical time of testing in the rest of the world also, what we do as an additional test. If the first test is normal, let's not miss the bus again. Do the same test again at 24 to 28 weeks, because that's the time full-blown high sugar can emerge. 10% is the least of the incidents we are speaking of. It's now raised to about 20-22%, but presuming 10% of the women will test positive, that is, after you give them 75 grams of glucose, fasting, non-fasting, doesn't matter. Whenever she's available, just give her 75, just go for it, is what we say. And in 2 hours time, draw 1 blood sample, and if the sugars are more than 140 mg%, she is a case of hyperglycemia in pregnancy. If you find 10 out of 100 women like that, you will first, of course, do the medical nutritional therapy as a broad control. Give her 2 weeks time. If the sugar is not under control, then you will start adding the pharmacotherapy in the form of metformin, and sometimes maybe you will need the insulin as well. Many times in many public institutes, we see many patients admitted for the usage of insulin because the testing has been done so late, the diagnosis is so late, and the sugars have already escalated into 100, 200, 300, and then they need them to be admitted and the insulin given to get the whole control within that. So universal testing is the rule, especially in the Asian countries, and take the first step, the Pehla Kadam, test all pregnant women with 75 grams with a single step test. This is something of each one teach one, just like this little baby is trying to tell her mother that don't miss out on taking the 75 gram glucose and get tested. Huge advantages, because single step, single visit, single prick, saving time, saving cost, and getting the diagnosis right there. And why is it so important to test early? Because it's your opportunity to start managing early, because preconceptional care is dismal in the country. Early bookings are also now improving. Don't lose out on the chance to actually do the best. You will see that we have taken to the streets. As I said, Sneha will not leave anything unturned. Like that, we also left no stone unturned. You see us walking saying, defeat diabetes, don't let India be the diabetic capital. And you see Rishi there with Nari Swasthya Andolan, which started long back, about a decade ago, saying that we have to do the best for our women. So what targets? Hyperglycemia. So your main aim is to get the sugars to normal levels. So fasting and before meal, it should be 90-95. 2 hours after a meal, 120, and HbA1c less than 5.2, 5.4. That is the ideal. So the practical approach for counseling, they say, okay, in a hi-fi setup, send off to a dietitian. And first of all, the patient is so psyched up, that new person dietitian, she gets totally, overboard, and she listens to carbohydrates, proteins. She can't understand anything. Different types of cuisine in our country. And if you tell a South Indian, machi khao, meat khao, it is not going to work out for us. And the strong carbohydrate content of rice and wheat preparations is again a huge challenge. So 5 minutes, 5 steps is what we call. Reduce the portion size or the grain size. No going beyond 2 numbers of idlis or dosa or roti or chapati. Keep the numbers small. No going beyond a small bowl of soup or of rice, uppa, poha, whatever. So if you keep the proportions small, it's easy for the body to handle whatever amount of carbohydrates you're giving. Then the frequency of meals. 3 small meals, 5 snacks, so that you're taking breaks in between, so that whatever insulin is available, it will act well and control the sugars. The protein source, very, very important, because if you hike up your proteins with all the little things which are written out on this slide, especially the dals and the paneer, soya, etc., should be taken in large quantities. No going to the bakery, no packaged food stuff, and for those small snacks that we suggest, add roasted chanas, nuts, seeds, cut fruits, salads, etc. So in a quick fix way, you have to tell her all of these in 2 to 5 minutes, available to you in the rush to OPD. It is better many times than what she can listen in a theoretical manner from the dietitian. Please, please, please pay attention to the weight gain, because visit after visit, somebody else may be seeing her, but if the weight is kept in the proper column, normal pregnancy, we allow 10 to 12 kgs, but here you have to restrict it to 6 to 8 kilos. And this is a non-negotiable. See, we say resource doesn't matter. High resource country, low resource country, middle resource country, but everybody can exercise. It is a low cost, no investment. So when we put these pictures in the FIGO team, they could not relate to the central picture of Jhadu Patka, because they didn't know what this lady was doing, because they are so used to vacuum cleaners. So whatever is the physical form of exercise, upper body exercise, give her a small video clip, or refer her to some YouTube sites, and she can do it. So this is just to recap that test everybody. If she's more than 140, get on with the medical nutrition therapy, then add metformin, add insulin, and let your diet counseling be very, very specific and robust. Metformin, but many of the PCO patients may be continuing till 12 weeks and can, if needed, after 20 weeks when you're diagnosing, you can straight away start with MNT. If it doesn't control, metformin is a prescribed next alternative. These are a variety of insulin. I would rather suggest that you network with a diabetologist, because sometimes it's very difficult for us to remember all the newer kind of insulins and the way they act and what is the best thing to be given. Really, if your patient is escalating sugars, please do not hesitate to seek help. As obstetricians, not only sugars, we are worried about so many things, comorbidities. Anemia is there, undernutrition is also coupled with this, and PIH is often a comorbidity. Then this lady lands up with a polyhydramnios, inappropriate weight gain, then with distension of the uterus, premature labor, delayed lung maturity, uncontrolled sugar in the early part of the pregnancy, then congenital malformations. You have to worry about time, mode, place of delivery. So finally, when the important event of the delivery comes, 38 weeks is more or less the cutoff in controlled cases. And earlier than that also, sometimes with the history of previous stillbirths and very poor glucose control, many morbidities, and the surveillance has shown that it's better to act rather than to delay, and you to be wise to give the steroids under supervision, and you can deliver her. Fetal macrosomia with the confusing kind of weights that the scan machine will throw, please rely on your clinical judgment as well. And always in retrospect, when you get stuck with shoulder dystocia, you will think that, oh, I should have done a section. Okay, liberal policy towards C-section when macrosomia is suspected, that's generally the rule. Please do not forget, these fat babies are really sick, and neonatal hypoglycemia is equally a very challenging problem. Baby inside the womb is used to a 5-star meal and a high sugar atmosphere. It comes out, the mother doesn't breastfeed for a couple of hours, and the inadequacy of the sugars circulating in the newborn will really cause a lot of challenges, and many a times the babies will land up into neonatal care. Lastly, don't allow the dip to go to DAP, which means diabetes in pregnancy should not become diabetes after pregnancy. Don't let these women and the children lose in the population. Put something on their card to identify that they need care forever after. Year after year after year, they have to get their sugars checked, keep their weight checked, and manage their diet in a very disciplined way, so that within 2 to 5 years after their delivery, they don't turn into diabetes after pregnancy. As we are walking towards tomorrow, let us have the next generation in the best of health, because it all begins in utero, and all the programming, the health horoscope or health kundali is written when the baby is in the womb itself. So if you take care of the mother's blood pressure and sugars and the weight and the nutritional aspect and anemia, most likely that this horoscope will be well written and the next generation will remain healthy. How do we make all these happen in such a massive country like ours? You just see that every generation has taken to the use of mobiles. It can be used for advocacy. It can be used for capacity building. The awareness programs can be filled. Even today, it is used for just guiding the patients as to escalating the dose of insulin, vice versa, one way or the other. And a lot of messages on the diet also is given through the mobile. So let's not make any excuses that this, that, and the other is not available. With one mobile as a centerpiece, you can do a lot of things to get the girls and women out there into the best of health. With that, I wish a very bright future to all the bright young people who are here. And as we step back with satisfaction into a mentorship position, we are so proud and so happy to see the Towards Tomorrow generation grow into such a brilliant galaxy of obstetricians in our own country. Namaskar.
Thank you so much, ma'am. Dr. Shazia, we are waiting for your concluding remarks.
Yes, thank you so much, ma'am. And it was such a brilliant talk. And as usual, today you excelled in clearing all our doubts related to diabetes in pregnancy. And it was a beautiful revision in such a short span of time. And you have actually covered all the aspects in depth and very clearly explained the management and newer approaches on MNT and newer anti-diabetics. And I'm sure all of us have gained a lot of knowledge on diabetes because every time we see a new patient, we have so many dilemmas related to it. So the take-home message is that irrespective of the gestational age, we must do a glucose challenge test of all the pregnant patients and avoid doing the random blood sugar and fasting, because we need to subject the patient to the challenge and just see the how much amount of insulin she is able to mount up to get her sugars under control. So this way we will avoid missing any future candidate for diabetes in future. Plus we can easily manage the complications because of hyperglycemia for the baby and the fetus, because we are the first persons to whom the patient will face. So we may miss a wonderful opportunity of diagnosing hyperglycemia in pregnancy if we don't do a GCT. So thank you so much, ma'am, for such a wonderful talk. And it was an honor
Thanks,
to have you
everyone.
with us today.
Now we hand you over to Paramanand. Thank you.
Okay, thank you so much, respected Hima ma'am. Thank you so much to the chairpersons of this session, Pragati ma'am. She had a fetal distress case, and thank you so much, Dr. Shazia. For sure, it was a star-studded session. Moving ahead to the next one, which is going to be another enlightening ceremony for us. May I have the pleasure of inviting Dr. Niharika Malhotra to take over for this particular session.
Thank you, Dr. Sheila, and welcome everyone. And our next session is on fetal growth restriction. And for this session, I would like to invite the chairpersons, Professor Tamkeen Khan and Dr. Sabah. Professor Tamkeen Khan is from Aligarh, and she has more than 29 years of teaching experience and has guided and mentored many youngsters. More than 130 papers published in many index journals and more than 220 lectures all over India. She is also the master trainer for AMOGS, and her areas of interest are fetal medicine and high-risk pregnancy. Welcome, Tamkeen ma'am. Our next chairperson for today's session is Dr. Sabah, consultant OBGYN from Muradabad. She's the immediate past president of Muradabad OBGYN Society and an executive member of West UP ISOPAP. Also the secretary of Obesity and Endocrine Disorder Committee of Stillbirth Society, and she has published many papers in national and international journals. Welcome, Dr. Sabah, and I now request our chairpersons to introduce our speaker, Dr. P.K. Shah, sir.
Dr. Sabah has joined. Tamkeen ma'am. So meanwhile, I'm giving a call to them. Dr. Niharika, can you please introduce her?
It's such a great pleasure to introduce one of my favorite mentors who has always pushed and motivated us youngsters to do better in our field. Dr. P.K. Shah, sir, professor and unit head of OBGYN department of GS Medical College and KM Hospital, Mumbai. He has been the past dean of Indian College of Medical Ultrasound, past president of FOXY, past president of IG, also the past president of IFUMB, past president of Mumbai OBGYN Society. So he has touched all societies which we can think of. So it's such a great pleasure here, sir, to have you. And I can't wait to hear your talk on fetal growth restriction. Thank you
so much. Can I share my slides?
Yeah, Bhavna, you can stop.
Bhavna, please stop sharing.
Can you see it? Full screen? Hello?
Sir. No, sir.
No, sir.
You can't see it?
So full screen is not visible.
No, full screen cannot be seen?
No.
Okay, let me do it again. Now?
Yes,
sir.
Okay. Yeah. Thank you, Niharika, for your kind words. And at the outset, let me thank Dr. Sneha Boyar, Chairperson of Medical Disorder Committee of AMOGS, and all the office bearers of AMOGS for giving me this opportunity to talk to you on fetal growth restriction. It is nice to see that various societies like Agra OB-GYN, Bareilly, Aligarh, Moradabad, all these societies have joined, and I can see some of the office bearers of these societies being chairpersons. It's a good trend to have association of various societies in a webinar. Sneha has been a very close associate, and I think I am a common factor K for most of her programs. And I wish her all the very best for all her future endeavors. A very hardworking person, a very sincere worker of Foxy. So let us come to the topic, that is a fetal growth restriction. And move. Okay. What is small for gestational age? When you have a birth weight less than 10 percentile, it is called small for gestational age. There are two areas that you have to look at. One is genetically small, whereby the baby is constitutionally small, the parents are small. They are healthy small for gestational age because the Dopplers are normal. Fetal growth restriction is failure to achieve its growth potential. And majority of the Indians are small and have small, Indians have small babies. 50 to 70% of SGA fetuses are constitutionally small. Pathological or fetal growth restriction, they are about 30%. Constitutionally small, the parental outcome is usually normal. No IUFD, no signs of adaptation. Whereas in fetal growth restriction, you have poor parental outcome. You can have intrauterine fetal death, signs of adaptation, plus on Doppler examination. When do you call it as a sonographic diagnosis of SGA? When you have estimated fetal weight calculated by various parameters like VPD, HCA, CFL, etc., less than 10 percentile of gestational age. Not all SGAs are growth restricted. Not all FGRs have birth weight below 10 percentile, and even 10% of appropriate for gestational age fetuses may be growth restricted. So what is the definition of FGR? The estimated fetal weight less than 10 percentile according to American College of Obstetrics and Gynecology based on BPD, HCA, CNFL. They're all SGAs. But if the estimated fetal weight is less than 3rd percentile, as WHO says, it's a fetal growth restriction. The most common cause of premature birth and intrapartum asphyxia. Okay, now there is an extended definition of FGR, which should include these 3 parameters. Estimated weight less than 3rd percentile, cerebroplacental ratio less than 5th percentile, and uterine artery PI more than 95th percentile. So the fetal growth restriction is estimated fetal weight of less than 10 percentile plus any one of these 3 that I mentioned above. You all know the differences between small for gestational age and fetal growth restriction, so I will not go into the details of it. The overall frequency of FGR is around 6 to 8%. About 30 to 50% of extremely preterm units are also FGR, and it's responsible for almost 50% of perinatal mortality. The pathophysiology of uteroplacental causes is absent physiological changes in some segments of spiral arteries. The trophoblasts do not invade the spiral arterioles, and that leads to persistently high pressure in the placenta. So what is the pathophysiology? There is an inadequate trophoblastic invasion of the spiral arteries. There is absence of uterine vasodilatation. there is reduced placental perfusion, hampered venous microcirculation, umbilical hypoxemia, and vascular changes for compensation. What is the growth? I don't know whether this upper part I am getting this. I don't know, this keeps coming all the time on the top, whereby I can't see my slides.
Mhm.
Can we have this upper
Bhavna,
part?
Bhavna, can we solve Sir's query? He is facing some technical issues. Bhavna?
Sir, hello.
Yeah.
Sir, am I
Yes.
audible? Sir, you can actually go to the view section on the top of your screen.
You
And
options.
Yeah, make it side by side gallery. Is it visible now, sir?
I can't see the upper part of my slide because of this constantly this mute stop video, which normally is in the lower part, is here on the upper part. Anyhow, we all know that growth restricted fetuses have high mortality and morbidity because of intravascular hemorrhage, bronchopulmonary dysplasia, necrotizing enterocolitis, infection, pulmonary hemorrhage, hypothermia, and hypoglycemia. How to diagnose? We already discussed fetus with a weight of less than 10 percentile of the value for that pregnancy age with an increased HCAC ratio. The fetal growth restriction diagnosis implies evaluation of the fetal weight by ultrasound. How do you establish the gestational age? By first trimester CRL, which is the most accurate means of diagnosing the gestational age. Comparison with standard growing curves and calculation of the percentile. The serial evaluation of the fetus and calculation of individual growth curves is very important. You can't have one parameter done once and say that this is growth restriction. You have to have serial evaluation. Dynamic evaluation of the fetal growth, which will show you the trend and identification of a slowing or stopping of growth. Color Doppler detects deterioration of fetus 10 to 15 days before modality is available to us that can detect intrauterine fetal distress, that is cardiotopography, fetal biophysical profile. By color Doppler, we try to find out the cause, whereas CTG, fetal biophysical profile, detect the effect, and hence it is better to detect the cause than to wait for its effect to prevent delay in management. What is the role of Doppler in FGR? To identify etiology, whether it is placental or non-placental, to identify hypoxia and fetal adaptation, to plan timing of delivery, and to identify fetuses at risk of perinatal complications. What all vessels do we examine? To identify vascular bed resistance, you sample uterine artery, umbilical artery, identify fetal adaptation, you have the middle cerebral artery, and to identify cardiac decompensation, you have ductus venosus and umbilical vein. Now, there are two entities when you talk about fetal growth restriction: early and late fetal growth restriction, which are distinct by the moment of onset, evolution, Doppler parameters modification, and postnatal outcome. The best cutoff between early and late fetal growth restriction is about 32 weeks. What is Delphi's consensus when you talk about early fetal growth restriction? Gestation age less than 32 weeks, no congenital anomalies, abdominal circumference and estimated fetal weight less than 3rd percentile, or umbilical artery showing you absent end diastolic flow, or abdominal circumference, estimated fetal weight less than 10 percentile combined with uterine artery PI more than 95th percentile, and or umbilical artery PI more than 95th percentile. What about late FGR as shown by Delphi consensus? Gestation age more than 32 weeks in absence of congenital anomalies, and ACEFW less than 3rd percentile, or at least 2 out of the 3 following. 1, ACEFW less than 10 percentile, ACEFW crossing centiles more than 2/4 on growth centile, cerebroplacental ratio less than 5th percentile, or umbilical artery placental PI more than 95th percentile. Main factor for developing E or late FGR is the placenta, the resistance in placenta. Now coming to early IUGR, for fetal growth restriction, EFGR is considered to be a vascular disorder due to abnormalities of the tertiary venous vessels. Please remember this very clearly. Tertiary venous vessels. It is more frequently encountered in patients with preeclampsia, autoimmune disorders, and conditions that can affect the placental vessels, whereas late FGR is not connected to preeclampsia most of the times. Alteration of placentation has an important impact upon fetal growth, most affected being abdominal circumference, whereas biparietal diameter and femoral length are less modified. In this type of early FGR, the evolution is long enough to permit the development of a classic fetal asymmetrical hypertrophy that can be diagnosed by ultrasound. The long evolution is mainly due to the small oxygen demands of the fetal brain and to the long resistance to hypoxia of the fetal heart at this age of gestation. Sorry. What is the physiology of FGR? Reduced transfer of oxygen and nutrients towards the fetus. It leads to blood flow redirected towards vital organs like brain, heart, suprarenal glands, and reduced blood flow to muscles, bowel, liver, and kidneys. It is always a progressive Doppler alteration in EFGR. This you will always find in early FGR. Abnormal blood flow in placenta due to vascular lesions, increased resistance in umbilical arteries determined, peripheral fetal vasoconstriction and augmented umbilical artery pulsatility index. Then there is a cerebrovascular resistance is increased due to middle cerebral artery pulsatility index, an absent end diastolic flow or reversal of flow in umbilical artery, abnormalities in pulmonary and aortic outflow, tracks with cardiac insufficiency, and lastly, overload of the precordial venous system with AV absent or reverse in ductus venosus. In EFGR, the absent end diastolic flow or reversal of flow in umbilical artery are better correlated with fetal outcome than cardiopulmonary ratio. Absent or reverse umbilical artery and diastolic velocity have an independent impact on neurodevelopment after 24-26 weeks. There's a normal umbilical artery flow. There's an increased PI in the umbilical artery. And the one on the left shows you absent end diastolic flow, and the one on the right shows you reversal of end diastolic flow in the umbilical artery. Now, what are the predictive values of the umbilical artery waveform and indices? Impedance is increase in umbilical artery, and if it is more than 60%, that means 60% or more of the placental vascular bed is obliterated. Absent end diastolic flow and reversal of end diastolic flow have an associated 40 and 70% perinatal mortality respectively. That's a middle cerebral artery. The one at the top is normal, and this is decreased resistance to the flow of the blood in the middle cerebral artery, which is a compensatory mechanism. MCA-PI less than 5th percentile is an efficient tool for evaluation of cerebral vasodilatation. CPR less than 1, regardless of the evaluation methods, is associated with a poor perinatal outcome, the odds ratio of 11.7. So on one side, you have umbilical artery showing a high SD ratio, and MCA showing you low SC ratio or low PI. This is a compensatory vasodilatation. But abnormal umbilical artery and MCA Doppler remain the strongest predictors of adverse outcome, with only marginal added benefit of ductus venosus as an independent risk stratification as shown in 2010. PI ratio of MCA by umbilical artery, that is cardiopulmonary index or cardiopulmonary resistance, the most sensitive and specific index in predicting major perinatal adverse outcome, 83% and 75% respectively. This is a normal waveform pattern of ductus. This is a reversal of A wave in ductus venosus. Ductus venosus flow Doppler is a useful parameter since all the precordial veins, ductus venosus allows the most accurate interpretation of fetal cardiac function as well as myocardial hemodynamics. You can have a aortic isthmus studied because before the ductus changes occur, you will see the changes in aortic ductus venosus, whereby the absolute velocities are reduced in intrauterine growth restriction or FGR. Now, uterine artery Doppler may be performed at the time of 17 to 22 weeks in women with the following risk factors, which you all know very well, like any gestational hypertension, abruption, IUGR, stillbirth, pre-existing hypertension, gestational hypertension, etc. So what is the timeline for hypoxia in case of fetal growth restriction? When you have an abnormal fetal growth, within about 2 weeks' time, you will find abnormal arterial Doppler, and within a couple of days, abnormal venous Doppler. And then lastly, you will find abnormal cardiotopography or fetal biophysical profile score. Now, coming to late onset fetal growth restriction, it represents the failure of the fetus to reach its potential, growth potential at term. Fetal hypoxemia or hypoxia secondary to placental insufficiency represents the main cause of late FGR. In most cases, the placental lesions have a late onset and or do not have a significant extent of damage of placenta in order to increase the resistivity of the placenta and translate it into augmented umbilical artery PI. So in late FGR, in terms of frequency, LFGR is far more prevalent than early FGR. It has placental anomalies such as venous immaturity with less impact upon placental resistance. Therefore, the umbilical Doppler indices can be unaffected. Please remember this very clearly in late IUGR, late fetal growth restriction. Diagnosis of late FGR is more difficult due to the large variability of fetal parameters on growth charts in third trimester. In fetuses with late FGR, estimated fetal weight appears to remain within the normal limits of appropriate for gestational age fetuses at more than 10%. Suspect late FGR when the individual growth curve slows down or even becomes flat, and there is an increase of the HCAC is detected in previously normal growing fetus with normal parameters. Fetal brain at term has increased requirement of oxygen. Therefore, the first hemodynamic alteration in presence of hypoxia is cerebral vasodilatation. This method of neuroprotection cannot completely compensate the effect of hypoxia. The cardiac insufficiency does not have enough time to arise. Severity of cerebral lesions taking place faster and determining severe CTG alteration. Therefore, the classical sequences of Doppler modifications which are seen in early fetal growth restrictions are not present in late fetal growth restriction. During last 20 weeks of pregnancy, the brain increases in size by 17-fold. Late FGR fetuses are very fragile due to increased oxygen requirements of the brain. They present multiple risks due to their inability to tolerate hypoxia. Undetected FGR in third trimester of pregnancy represents the main cause of unexplained stillbirth in low-risk pregnancy. Remember this sentence very, very clearly. Many times we have in third trimester, baby dying without anyone knowing why. it could be undetected fetal growth restriction, that is late FGR. Also, probably a number of idiopathic cases of cerebral neonatal palsy, where an acute intrapartum hypoxia event could not be identified, are in fact caused by an undetected late FGR. The late FGR is a challenging diagnosis associated with increased fetal morbidity, mortality, impaired postnatal outcome, and suboptimal neurodevelopment. Doppler markers of cerebral vasodilation to be a landmark of late FGR. If you have MCA-PI less than 50 percentile, it is considered a marker of cerebral vasodilation. Even
Bhavna,
in
please
presence of
mute
a
others.
normal umbilical artery PI. If in the third trimester the obstetrician analyzes only the umbilical artery PI, these fetuses will be missed, and the potential intrapartum and postnatal complication cannot be anticipated. So LFGR fetuses have poorer neurodevelopment outcome and an increased risk of neonatal motor activity, lower score of communication and problem solving scores at 2 years of age. They are also at a higher risk of cardiovascular diseases, hypertension, glucose intolerance, diabetes, dyslipidemia, and obesity in childhood and in adulthood. The rates of acute fetal distress during delivery and number of emergency C-sections in late FGR with cerebral redistribution are significantly increased as per these three people. CPR should be considered as an assessment tool in fetuses undergoing third trimester ultrasound examination, regardless of the result of the umbilical artery and middle cerebral artery measurements. Even in AGA, appropriate for gestational age fetuses during third trimester, those with a modified CPR are at increased risk of perinatal complications. There are discussions about the utility of routine third trimester Doppler ultrasound for all pregnancies. I met Dr. Akolekar during AICOG at Kolkata, and he is of the opinion that it would be better if we do at least one color Doppler in third trimester for even low risk pregnancies to pick up late FGRs. Recent guidelines recommend delivery of LFGR fetuses with brain sparing effect because it is predictive of acidosis at birth. Cerebral redistribution may be used in association with the clinical elements in decision of delivery of LFGR fetuses, even in presence of a normal umbilical artery Doppler. The paradigm that a normal umbilical artery Doppler pattern in third trimester confirms a normal pregnancy and does not need any further Doppler evaluation of the fetal vessels definitely needs to be modified with important impact upon clinical follow-up. How do you manage the fetal growth restriction? There is no effective intrauterine treatment. Objective of a correct management are early diagnosis, prevention, and reduction of risk factors wherever possible, surveillance of the fetus with fetal growth restriction, and delivery at the best moment. If delivery before 32 weeks, consider magnesium sulfate for fetal neuroprotection. If delivery before 34 weeks, consider corticosteroids as indicated. Doppler ultrasound is the chief tool. What is the aim of delivery? Whether you want only a live fetus or intact survivability. The risk of intrauterine compromise has to be weighed against the potential risk from iatrogenic premature delivery. When to deliver now? Gestational age at decompensation is the primary determinant of perinatal survival. Neonatal care available dictates gestational age of delivery. Less than 32 weeks, every day gained is useful. Every week gain outcome improves by 40%. Here the venous Doppler help early delay delivery. So 32 to 34 weeks, give steroids and deliver once umbilical artery shows you absent or reversal of end-diastolic flow. There is a stage-based approach to management of fetal growth restriction. I want all of you to remember this by heart. Keep it in your labor ward. So whenever you have a patient of growth restriction, you can follow this. You must know what is the stage that the fetal growth restriction is in. Stage 1, severe smallness or mild placental insufficiency. Sorry. What are the criteria? estimated fetal weight less than third percentile, CPR less than 5th percentile, umbilical artery PI more than 95th percentile, and uterine artery PI also more than 95th percentile. Monitor weekly, and gestation age and mode of delivery, 37th week you should deliver, and you can use induction of labor. If it is stage 2, severe placental insufficiency, umbilical artery absent and diastolic flow, or reversal of aortic isthmus, then monitor bi-weekly, and you can deliver her by C-section at 34 weeks. If it is stage 3, low suspicion of fetal acidosis, whereby you have umbilical artery showing a reversal of end-diastolic flow and ductus venosus PI is more than 95th percentile. Monitor daily, deliver her by C-section at 30 weeks plus. If it is stage 4, high suspicion of fetal acidosis, ductus venosus reversal of A wave with CTG less than 3 centimeter, fetal heart rate deceleration plus, monitor her every 12 hourly and deliver by C-section at 26 weeks plus. If you have early onset fetal growth restriction stage 1 with high resistance in umbilical artery, CPR less than 5th percentile. Sorry, my throat is irritating. The weather changes. MCA less than 5th percentile and uterine artery more than 5th percentile. Monitor with NST, biophysical profile and VAST weekly, umbilical artery MCA Doppler weekly, growth parameters and AFI weekly, delivery at 37 weeks if all normal by induction of labor. Vaginal delivery is allowed. If it is early onset IUGR stage 2, absent and diastolic flow in umbilical artery, or reversal of flow in aortic isthmus, gestation age more than 34 weeks, give steroids, deliver by C-section. If the gestation age is less than 34 weeks, admit, give steroids, do Doppler of umbilical artery MCA and ductus venosus bi-weekly, and C-section if ductus venosus shows reversal of A wave. If it is early onset IUGR stage 3, reversal of end-diastolic flow in umbilical artery or ductus venosus PI more than 92th percentile, gestation age more than 30 weeks, give steroids and magnesium sulfate, deliver by C-section within a day or two if estimated fetal weight is salvageable. But if the gestation age is less than 30 weeks, this is an according to estimated fetal weight and NICU facilities. Rescue steroid magnesium sulfate if ductus venosus flow is normal. Daily Doppler C-section if ductus venosus shows you reversal of A wave. Do induction of labor with consent for intrapartum death. If it is stage 4, early fetal growth restriction, pathophysiological correlate, high suspicion of fetal acidosis, criteria, ductus venosus reversal of A flow, CTG less than 3 centimeters, fetal heart rate, decelerations, do monitoring 12 hourly, and the mode of delivery around 26 weeks by C-section. You must talk to the parents thoroughly about the risk. Now, what about late onset fetal growth restriction? When there is a mild placental insufficiency, whereby you have fetus less than 10% flattening growth curves in third trimester, but it is more than 32 weeks. Normal umbilical artery Doppler, low PI, say cerebroplacental ratio less than 1. Uterine artery Doppler is abnormal, like a normal or low, not associated with preeclampsia. Monitor weekly Doppler, monitor growth and Leica. Now, if gestation age is more than 37 weeks, deliver her. Allow vaginal delivery. If gestation age is less than 37 weeks, give steroids. Do Doppler of umbilical artery. PI more than 95th percentile, CPR less than 1, and estimated fetal weight less than 3rd percentile. If any one of the above abnormal, consider immediate delivery. Monitor for serial worsening of MCA PI if it is more than 95th percentile. If late FGR more than 34 weeks, delivery at 37 weeks at cases with increased PI of umbilical artery. Delivery between 37 and 38 weeks at cases with normal umbilical artery Doppler but modified MCA. The timing of delivery is based on MCA Doppler in cases with normal umbilical artery Doppler or with abnormal umbilical artery PI, but end-diastolic velocity is present. A good obstetrical condition, induction of labor can be offered, but rates of emergency C-section are increased. Early admission is recommended in women in spontaneous labor with SGA fetus in order to instigate continuous fetal heart rate monitoring as per RCOG guidelines. Fetal heart rate monitoring will be interpreted more cautious than usual. What is the conclusion? That leg fetal growth restriction onset after 32 weeks, PIH need not be there, high index of suspicion, umbilical artery Doppler may be normal, always combine umbilical artery and MCA and CPR. The cardiopulmonary ratio is very important for decision making. When to monitor begins with the onset of intact survivability in fetal growth restriction fetuses. What to monitor is a combination of arterial and venous Doppler with input from biophysical variables in compromised fetal growth restriction. How often to monitor depends on the anticipated speed of clinical deterioration. Delivery is indicated when the risk for fetal acidemia or stillbirth outweigh the likelihood of meaningful extension of pregnancy. So the last slide, differentiate between constitutionally small and fetal growth restriction by composite of growth curves like COR and Doppler. Many so-called constitutionally small babies will be redefined as fetal growth restriction, adding CPR, uterine artery Doppler, and estimated fetal weight below 3rd percentile. Doppler of umbilical artery, MCA, ductus venosus, and aortic isthmus are useful for monitoring and timing of delivery of fetal growth restriction. Pathological growth restricted fetuses have higher morbidity and mortality rates and hence require more intense surveillance. Thank you very much, ladies and gentlemen, for your patient hearing.
Yes, any comments from the chairpersons? Yes, Niharika, sir.
Have they joined?
Yes, sir. Tamkeen ma'am is here, sir.
Good evening, everybody.
She joined initially only, but I think some network.
I had joined, but there was some internet connection exactly at that time when I was supposed to introduce Dr. Shah. I'm really sorry for that.
It's okay.
And thank you so much, Dr. Sneha, for the invitation. I remember Dr. Shah's slogan when he was the Foxy president in 2012. Life of every mother and neonate counts. So I think this lecture was about, saving lives of neonates with so much talk about stillbirths. So an excellent, a very comprehensive and concise presentation, Dr. Shah.
Thank you.
And I would just like to summarize a few take-home messages and add a few points from my own experience.
Yeah.
Previous history of FGR increases the risk of stillbirth in the current pregnancy by a higher times rather than a previous stillbirth itself. And always we need to have a very high index of suspicion, otherwise we are going to miss it. So a good clinical examination of patients is very important because unless you suspect, you will not be able to use the most important tool, that is sonography. So this is especially true for those who are working in resource-poor settings and in public hospitals. Apart from that, passive smoking of mothers, a family sleeping in a room of 8 by 8 with the husband smoking throughout the night. That is also a very important cause of FGR. Serial ultrasound is the most important tool for management. A single ultrasound will not be able to differentiate. SGA babies are high risk, but even appropriate for gestational age may have FGR, as we do not know the actual growth potential of each baby. For example, in diabetes, the baby weight may be 3.5 kg and the liker may be absolutely fine, but she may be FGR. She may, because the diabetes is not controlled, and again, she's developing the uteroplacental insufficiency. Earlier, she was polyhydramnios. Now she is normal liker, and you may miss it. So even these babies will require a Doppler study. At the same, this is what I wanted to just, emphasize. And whenever you have cases of very early severe FGR, genetic studies are very much indicated. And I think it should be our habit to send the placenta for examination. Many a times we'll be able to find and we'll be able to know what happened to the poor neonatal outcome or why a stillbirth occurred. So that is also a very important, tool for managing the next pregnancy, at least, if we were not able to save the current baby. So thank you very much.
Well said. Absolutely perfect. Thank you. Niharika.
Thank you so much, sir. Thank you so much, Tamkeen ma'am. Ma'am is my teacher. So when Niharika was introducing, ma'am has guided and done so many things. So we owe everything to ma'am for teaching us right there. And PK Shah sir, your lecture is always amazing. I remember my PG days. In one of the PG focus, we were awestruck by the way you spoke, and all the PGs were listening to you and celebrating your talk. Ki wah wah kya padhaya sir. So thank you so much. And today also it was like that.
Thank you so much.
So, thank you, sir.
Thank you so much, Shaila.
We were waiting for you.
Thank you so much, everyone. And thank you, PK sir, for this wonderful talk. And thank you to our respected chairpersons for this session. Let's move forward to our next session, the panel discussion. So as you know, we are covering three most important aspects of obstetrics, that is gestational diabetes, fetal growth restriction, and now hypertensive disorders in pregnancy. For this panel discussion, we have our very own Dr. Sneha Bhuyar as the moderator. She is the AMOGS chairperson of Medical Disorder Committee, and she has done tremendous work under FOXI as being the chairperson of the Breast Committee. Our expert for today is Dr. Naren Malhotra. I would also like to introduce the panelists here. So our panelists for today are Dr. Anubha Agarwal, who is a gynecologist and obstetrician from Bareilly, Dr. Shraddha Maheshwari, executive member of Bareilly OBGYN Society, Dr. Shubhra Agarwal, professor OBGYN from Muradabad, Dr. Dipali Verma, fetal medicine and high-risk pregnancy expert from Muradabad OBGYN Society, Dr. Jaya Sharma, leading practicing OBGYN, Dr. Mohita Agarwal, professor in Department of OBGYN, SN Medical College, Agra, and Dr. Abhilasha Yadav, assistant professor, Department of OBGYN, SN Medical College, Agra. I now invite Dr. Sneha Bhuyar to take this panel further.
Thank you so much, dear Dr. Niharika, for introducing the panelists and sharing my work. I would like to welcome all my panelists, Dr. Anubhuti, Dr. Shraddha, Dr. Shubhra, Dr. Dipali, Dr. Jaya, Dr. Mohita, and Dr. Abhilasha Yadav. Bhavna, you can stop sharing and let me share my screen first. Can you all see my screen?
Yes, ma'am.
Yes. So I welcome all the esteemed panelists, and as Niharika has already talked about, that we are talking about these three most important aspects. And as all of you know, dear friends, that hypertension, hemorrhage, and these are the three major killers of the women, of our women in the reproductive age group. Prediction, knowing the predisposable factors. Prevention, the avoiding the exacerbating or aggravating factors. And preparedness, to have the knowledge and to implement. This is the key to success. Careful history taking, especially the maternal characteristics, family and medical history, and of course the HTP, gestational score, which we are talking about a lot nowadays. Certain biophysical and biochemical tests, these can predict hypertensive disorders of pregnancy, and definitely low dose aspirin and high dose calcium and vitamin D does have a role of prevention. Even though we can't prevent the preeclampsia or hypertensive disorders, we can at least minimize the complications associated with it, and we can reduce the maternal mortality. You can see here the past FIGO president, Professor Mohammed Patala, what he has said. Women are dying of the diseases we cannot treat. Women are dying not because of the diseases we cannot treat, but because the societies have yet to make the decision that their lives are worth saving. So friends, let us all decide that yes, women's lives are very, very precious and we are the saviors. Definitely, we are not going to go into the theoretical aspects. All of you know what are the screening for preeclampsia, what is the role of the maternal characteristics, what is the role of the uterine artery pulsatility index, what is the role of the mean arterial pressure, and we have to know how do you measure the mean arterial pressure. I'll just quickly run over it. The mean arterial pressure is the pressure that is 2/3 diastolic plus 1/3 systolic blood pressure. Normally it is around 60 to 65 and the cutoff limit is 85. If it is more than 85, then it is significant, provided you have taken the blood pressure with all the criteria fulfilled, that she has to be at physical and mental relaxation. She should not have consumed any other drugs or caffeine. She should not have added some, dilators in the which are used in the ophthalmic management, and the bladder should not be full. She should be comfortable, and her clothing must be comfortable. The cup side should be good. So all of these factors which we have to consider. So with these basic facts, I think we would go straightway to the panel discussion. And Dr. Jaya, this is the first case for you. We have this 26-year-old primary gravida who has had an uneventful course till now. And now she's seen at 28 weeks. When you examine, you find the blood pressure is 140/94 millimeter of mercury. She doesn't have any symptoms. When you do her urine examination, there's no proteinuria. What do you think? How should you evaluate this patient and how should you manage this patient? Please unmute yourself. Dr. Jaya, please unmute yourself. We can't hear you. No. Can anybody hear Dr. Jaya?
I'm not audible.
No, ma'am.
Yeah, no. We can't hear you, Dr. Jaya. You need to check your device. Can somebody else take up this case, if at all? Somebody else can take up this case. How do you manage? What do you feel is the diagnosis, whether she is having hypertensive disorders, and how do you confirm that?
Yes, ma'am, maybe a case of hypertensive disorder of pregnancy. So in order to confirm, we have to repeat her BP, preferably after 4 to 6 hours. And if 2 consecutive BPs are suggestive of such high reading, that is 140/90, we can label her as gestational hypertension.
Okay, okay. So do you like to hospitalize her?
I'm not
do you like to start antihypertensives?
I'm not at this BP at 140/90. I may not hospitalize her. I may start her on antihypertensive, preferably labetalol, 100 milligram TDS.
Okay, so you will not hospitalize her. But then how do you evaluate her? What investigations do you want to do?
Ma'am, I would like to get her CBC done, LFT and KFT, with a urine dipstick by a reagent strip test. And if it is suggestive of 2+ or more, that is going in favor of severe, then I may hospitalize this patient.
Okay. So, Dr. Jaya, is the problem with your device sorted out? Can you please speak? Try and speak? No? Your device volume is very low. I think you need to increase that. Go to the right corner bottom of your laptop and you see that your device is on full sound. right, lower. No, you need to take some help. Okay, so you have rightly pointed out that 140/90, because if the blood pressure is 140/90 for a single reading, you don't label it as hypertension, you reconfirm it after 4 hours, and if it is still the same, it has to be labeled as hypertension. But knowing the severity of the disease, it's not only the blood pressure. Blood pressure is not a very good predictor of severity. So you have to do the lab investigations. Now, suppose you have done the laboratory investigations. Now, when do you label her as having a mild or a severe hypertension? And how do you manage this patient? Suppose you have evaluated this patient and all her investigations, lab reports, they are normal. So what advice do you give her?
Am I very audible, ma'am?
Yes.
Yes, ma'am. As this patient is young patient and she is mild hypertension.
How do you know that she's a case of mild hypertension?
Mild, even rather than gestational hypertension, because her BP is not that high. It is around 140/96. It is not that in the severe grade. Once the BP goes beyond systolic 160 and diastolic 110, then only we can label it as a severe one.
Okay. So you have done her. See, we have already discussed that only blood pressure is not a predictor of.
Exactly.
So when you go for her lab evaluation, suppose you find that her liver enzymes are elevated, her kidney functions are little impaired, then how do you label this patient?
Then we will label it as a severe preeclampsia. And we will admit her. It's a sort of atypical preeclampsia rather.
Right.
So we will admit her definitely. If their BP, then liver enzyme is elevated, then we have to monitor it with all the other parameters like twice a weekly test, the fetal Dopplers, the maternal and fetal both part to be taken seriously.
Right.
A fetal Doppler is to be taken and she has to be admitted under the supervision.
Okay. So what is the criteria for starting the antihypertensive? That is the question.
Yes, ma'am.
At what level of blood pressure you start the antihypertensives?
Ma'am, as per the ACOG criteria, we usually start the antihypertensive when the systolic is above the 150 mm of Hg and diastolic is more than 105 rather.
105. Okay.
Yes.
So NICE and ACOG guidelines say that 150/100 millimeter of mercury, that is the cutoff limit where you have to start antihypertensive. But I'm sure majority of you must have seen a patient convulsing even with 140/90. So how do you explain this? So to explain this, we have said that blood pressure is not a very good predictor of the severity. When you evaluate the patient and you find the parameters are impaired, then you label her as severe hypertension, even with this level of blood pressure. Okay, that is one. Secondly, gestosis. The World Gestosis Organization says that even with 140/90 millimeter of mercury, we should start antihypertensives. The reason being, when we define hypertension, we say that it should be increase in the systolic blood pressure by 30 millimeter of mercury, or increase in the diastolic blood pressure by 15 millimeter of mercury. So if our baseline is 100/60, okay, so that is how you calculate that even if with 140/90, we should start antihypertensive. Now suddenly you find that you have evaluated her, you have just advised her mental and physical relaxation, and you have called her back. Now see, at 32 weeks of gestation, this lady comes back to you with severe headache, epigastric pain, blurring of vision, and proteinuria 3+. So how do you manage this? What do you label this as?
Thank you, ma'am, for the question. Ma'am, this patient is now developing severe features. So she's a case of preeclampsia with severe features. Now she needs to be managed as a high-risk patient. She may need a prophylactic dose of magnesium sulfate, which is the same as that of the therapeutic dose.
Yes.
Apart from this, because she's at 32 weeks of gestation, we need to give her a steroid coverage, because we may need to terminate the pregnancy in these cases. Certain investigations need to be done to confirm end organ damage, whether the high blood pressure has affected her liver, her renal functions, her retina needs to be examined, and thereafter plan of delivery has to be planned as early as possible. In these cases, we may have to wait for 24 hours for the steroid coverage. And antihypertensive, the dose of antihypertensives needs to be titrated and may have to be increased accordingly.
Yes. So this is a chart which is showing, that blood pressure is not always a very good indicator for severity. You need to watch for the alarming symptoms and alarming signs. And of course, you have to wait for the laboratory investigation. If she is having significant proteinuria, if she is having oliguria, if she is having elevated serum creatinine level, if she is having thrombocytopenia, maybe impaired liver enzymes or elevated liver enzymes, as we say, and maybe the fetal growth restriction. So all these features put her at in the category of the severe hypertension. Now, your patient is clearly suggesting that she is landing up into, she is a case of imminent eclampsia. She's having all those alarming symptoms and signs. So to avoid the convergence, as Dr. Mohita, you have rightly pointed out, that you will start with her full dose magnesium sulfate regime, that is the Pritchard's MaxHerbs regime. We will come to it because we have one more case of eclampsia ahead. So we will discuss it later. Now, after you have controlled her, you have prevented her convulsions. Now suddenly she complains of bleeding per vagina. She also complains of mild dull ache in the abdomen. And you have already hospitalized her. When you examine, you find the blood pressure is 150/100. Uterus is contracted, cephalic presentation. Fetal heart is still good. Cervix is tubular, closed, but bleeding per vaginum is present. And when you do her ultrasound, you find that there is a retroplacental clot of 3/4 centimeter. Rest of the findings are normal. What do you feel? What has happened to this lady now? What complications she has developed? And how do you manage it? Yes, Dr. Mohita.
Ma'am, this patient has developed placental abruption as a complication of severe preeclampsia. In this case here, we would have to look for the fetal status, whether the fetus is whether the fetus is compromised or it is alive, and we have to plan a immediate delivery.
She has already had abruptioplacentary.
So we have to plan it
right now is good. Okay.
So, ma'am, in that case, we have to go for an emergency cesarean section to salvage the baby.
Yes, but before that, would you like to investigate her?
Yes, ma'am, definitely we would. Ma'am, we would yes, ma'am, we would definitely look for her any renal compromise and liver compromise, and coagulopathy definitely we'll have to rule out in these cases.
Correct. So, Dr. Abhilasha, are you here?
Yes, ma'am.
Yeah, so Dr. Abhilasha, actually, this is a question for you. Dr. Mohita has already discussed that before going for any emergency operative procedure, exactly you are suspecting here, what are the parameters you will be looking for, and how do you score it?
For this, we have this doses score for
this
of preeclampsia. And for this,
no, we have
DIC
already come to abrupt.
DIC score is there, which we have different parameters to know that whether this patient is in DIC or not. If the score is less than 5, we will consider that it is not a case of DIC.
So
and
what parameters you will look for?
In this, we will look for INR, fibrinogen levels, D-dimers.
Yes. And apart from the routine bleeding time, clotting time,
platelet count.
Yes. Prothrombin time. Activated partial thromboplastin time, serum fibrinogen and fibrinogen degradation products, D-dimer and FGP. Okay. So how do you score this patient? And what is the significance of this scoring?
Significance of the scoring is less. If it is less than 5, then it is not the case of DIC, and if it is more than 5, then DIC is there.
Okay, so how do you score it? What parameters? I have displayed it here.
These are the parameters, na? Platelet count, fibrinogen level, D-dimer, PT. FTP, these are the parameters.
Okay. So if you have more than 5, she's got over DIC. If the score is less than 5, then she doesn't have over DIC, but the test needs to be repeated every alternate day. Okay. If you are having any doubt as far as the platelet count and the rest of the coagulation profile, it needs to be repeated every 24 hours. Okay. So So as per the investigation reports, whether the patient needs that whole blood or packed cell, whether the patient needs platelet concentrate, whether she needs fresh frozen plasma, or whether she needs cryoprecipitate. That is to be decided, right? Basically, in this case, what you have to understand is blood pressure is not a good predictor of severity. Whenever you have a patient of blood pressure 140/90, do not just relax. You evaluate her completely for the maternal as well as fetal well-being. You do her laboratory investigation, see that she's not landing up into any complications. At that point of time, you start antihypertensive. That is a learning lesson, because once you do not act effectively at the appropriate time, the complications are likely to happen. That is what the learning lesson from these cases. So thank you, Dr. Jaya and Dr. Mohita, Dr. Abhilasha as well. Dr. Anubha now, this is a case for you. Anubha, do we have you here?
Yes, ma'am.
Yes, yes. So you have this 22-year-old primigravida belonging to a low socioeconomic status. She has no known medical illnesses previously, no significant family history as well. She's a booked case and up till now uneventful course. Suddenly at 30 weeks, she presents to you with blood pressure of 160/110, and you find her proteinuria 2+ on dipstick. What is your diagnosis? How will you classify this case, and what things have gone wrong as far as the prediction and early diagnosis is concerned? Yes, Dr.
Ma'am, patient is primary gravida, belongs to low socioeconomic status, and
what is the diagnosis here?
My diagnosis is she's a case of severe preeclampsia. Because there is proteinuria 2+ on dipstick.
Yes. So how do you classify this case? What kind of hypertension is this? It's a severe hypertension.
It's a severe hypertension, and because it developed after 20 weeks, so it is a case of preeclampsia, PIH.
Okay. Yes. So would you like to admit this patient? What investigations you would advise?
Yeah, yes, ma'am. I will like to admit this patient because she's 30 weeks having the severe hypertension, and in investigation, I will
irrespective of gestational age, because she's having a severe hypertension, you have to hospitalize her first.
Yeah,
okay. Yeah. What drugs you begin? What investigations you want to do, and immediately which antihypertensives you want to start for?
Ma'am, I will like to go for CBC, LFT, KFT. I would like to see serum creatinine, uric acid, PT, APTT, the whole coagulation profile, and optic color Doppler. And I will also like to see the maternal kidneys and liver to rule out any subcapsular hematomas, renal parenchyma. I would like to see in the Doppler, we see the uterine artery and the umbilical flow. And where placental maturity, its morphologies, plus any placental hemorrhage. Fundus examination is very important because she is a case of severe preeclampsia.
Okay. You have investigated her properly. Which antihypertensive? Because it's an emergency, 160/110 millimeter of mercury. What all things you want to start her?
Immediately, I would like to give the labetalol after ruling out the any history of asthma. So initially, we can give
oral or IV.
Initially, I will give injectable labetalol to stabilize the BP.
How much and how?
20 milligram
Yes,
of
yes.
lansoprazole in dilution of 20 ml, giving in 20 minutes slowly. And again, we check the BP after the 20 minutes, and we can repeat the
10
dose.
minutes. 10 minutes. It's only 10 minutes. Okay. So how much dose you want to repeat? Suppose there is no significant fall. What is the regime? How do you follow it? Because this is an emergency. So we have to control her hypertension. We have two drugs in hand. One is oral nifedipine and second is intravenous labetalol. So how much labetalol and how? And maximum how much? Anybody can take up this. Yes, Dr. Jaya, please unmute yourself.
We give labetalol first 20
Milligram intravenously, yes.
Then we check after 10 minutes. There's no significant fall in the BP. Then we have to rise it to 40 milligrams.
Wait for another 10 minutes.
10 minutes.
Yeah.
If it is still not coming down, then we have to make it 80 milligrams.
Correct.
We have to rise in twice. And the maximum dose is 20 to 1200 milligrams for the labetalol. 1200 milligrams.
Is it?
The 1200 is oral.
Ma'am,
300 is 300.
Maximum dose is 300 milligram.
maximum is 300.
Okay,
Yes, ma'am.
so 20, 40, 80, and you may repeat another 80, but not
Repeat
beyond.
the 80.
Yes.
Okay.
So this you have to remember. So maximum dosage is 300 milligram. Suppose you do not have intravenous labetalol, which drug will you prefer?
Oral labetalol.
Oral nifedipine. Oral nifedipine. How much and how frequently? Nifedipine capsule you must be using 10 milligram capsule.
Yes, ma'am. It is not given sublingually. Please stop doing sublingually.
It is oral. That is what we are saying. Oral. Yes.
Yes, ma'am. And we can give 20 milligram stat. And we need to check the BP again. 15
start with 10 milligrams. Suppose how much do you wait? What is the onset of action? What is the peak action for nifedipine?
Nifedipine.
The onset of action is within 10 minutes and the peak action is at 30 minutes and the duration of action is 6 hours. So the dosaging of nifedipine is 6 hourly. Okay. So, but if you give 10 milligram oral capsule nifedipine and if you don't find significant fall in 10 minutes, maybe it remains the same. You have to repeat another 10 milligram nifedipine orally. If at all there is a fall and you need to maintain this, your peak action is observed at 30 minutes. You have to maintain this dosaging every 6 hourly. Because this patient, now suppose this patient has severe hypertension, as you have said it well, and she doesn't have any alarming symptoms, right? So you want to give only antihypertensives and control the complications, control the blood pressure to avoid all the complications. Suppose this patient also has severe headache and blurring of vision, then what do you do?
Full dose of magnesium sulfate has to be given to this.
Even though we label it as prophylactic magnesium sulfate, that is prophylaxis against convulsions. So even if we say it prophylactic magnesium, it has to be a therapeutic dosage of magnesium sulfate, the complete pre-charged magnesium sulfate regime. Okay, so how much max sulf and how do you give it?
5 ampule I am in each buttocks. And
you start with preachers. May I know who is speaking? Dr. Anubha. We have to give initially the intravenous dose. So we talk about the intravenous dosage first. How do you give it?
Ma'am, we'll give 4 grams of 20% magnesium sulfate intravenous. That is 4 grams means 4 ampules. That makes 8 ml and we diluted to 12 ml. So that makes it 20 ml and we have to give it slowly intravenously over a period of 3 to 5 minutes. It has to be really slow. We cannot give a bolus dose and this has to be accompanied by an intramuscular dose of 10 milligrams, that is 10 grams, that is 5 grams in each buttock. And this is the initial loading dose and this has to be followed by the maintenance dose. This is the standard Pritchard regime.
Yeah, how do you monitor Pritchard's regime? You have to complete it first. So this is the initial loading dose, 14 gram loading dose. Then you give 5 gram deep intramuscularly every 4 hourly.
Meanwhile, what
Yes.
all things do you monitor?
We will check the respiratory rate, patellar jerk, and the urine output. Should be 30
Correct.
ml per hour.
Yeah. So initially, only one precaution. For magnesium sulfate, you said 4 ampoules, that is 4 gram. So for that, you have to make sure that always you use 50% weight by volume. Yes. So it has to be a 50% constitution of the magnesium sulfate, and you have to take 4 ampoules, that goes to 4 grams. You dilute. 4 grams is 8 ml. And you dilute it with 12 ml of normal saline or distilled water, and then you give slowly. That is what, of course, you have said it, but then you have to monitor. At any point of time, you find either the patellar reflex is absent or the respiratory rate is either very low. How much low and how much high? Can somebody throw some
12.
light?
It should be less. If it is less than 12, in that case, we have to withhold the dose.
Yes, either less than 6 or more than 40. Then you have to skip that particular dose of magnesium sulfate. So we were talking about the basic investigation. I don't think we should go into the details of this. I will just skip this slide. All of you know this very well. Proteinuria, only I would like to ask you whether she has proteinuria that is significant, or there is something like significant proteinuria. Can somebody throw some light on this?
Significant proteinuria when it is more than 300 milligrams.
300 milligrams per cent.
In 24 hours.
So you have this dipstick. You can have this exact measurement. You say negative when it is 0, 15 to 30 milligram percent it is stress, and 1 plus is 30 to 100 milligram percent, 2 plus is 100 to 300, and 3 plus is 300 to 1000, and of course anything more than 1000 is 4 plus. Okay, so we will not go into the details. We have just talked about the significance of the coagulation profile just now, and this is what the importance of the peripheral smear. It gives you an indication about two things. One is the hemolysis, the broken, irregular, damaged RBCs, and of course the platelets you can make out if it is lower in number. So when to start antihypertensives, we have talked about that. SEOG and NICE says that you have to start antihypertensives at 150 by 100, but the World Gestasis organization says that you have to start it on 140 by 90 millimeter of mercury. Which drugs and how we have already discussed that labetalol intravenously, we have discussed it indeed. You can see here maximum of 300 milligram. So this is a original table from World Gestasis, the module prepared by the Gestasis organization. Nifedipine, you can see 10 milligram, start with 10 milligram. The onset of action is 10 minutes, peak action is 30 minutes, and duration of action is 6 hours. You have one more option for the intravenous, the drug, that is hydralazine, where we start with 5 milligram intravenously. If available, this is also a good option for you. So, Dr. Shraddha Maheshwari.
Yes, ma'am.
You have this question for you. How often will you repeat the investigations? You have done the investigations initially. So how often will you repeat the investigation?
Ma'am, CBC, LFT and KFT, if they are on their higher side, means patient is having severe preeclampsia, will repeat these investigations daily.
Yeah.
And if the BP is controlled, then we'll repeat the color Doppler bi-weekly. And Maxelf regime, we are giving the whole regime. And if the patient is controlled, we are also giving the steroid cover if the patient is a preterm fetus. And in that case, we'll then, after 24 hours, we'll see the BP. And then depending on that, we'll think we should have to terminate the pregnancy, or we may continue for a few more days.
Yes, correct. So the dictum is that mother's life is first. So if you have a pregnancy of less than 26 weeks with severe uncontrolled hypertension, when do you label this as severe uncontrolled hypertension? When you have already used 2 antihypertensives and still she's not controlled on that. At the same time, if she is having liver enzyme elevation and renal function impairment, when do you label the liver enzymes as elevated? just for the practical purpose.
Ma'am, when FDOT and LGBT are more than twice the normal limit, and this LDH is more than 300.
Correct. So this you have to know, otherwise any level you will say more than 300, 400, it is elevated. So if it has to be more the double the baseline, more than twice the normal. If it is elevated, then you have to label it as elevated liver enzymes. So for such cases, when you find that there is organ damage, or if the fetus is also growth restricted and there is no possibility of further survival, it's better to terminate. But this is a period 26 to 34 weeks where you actually go for the expectant management and you have a scope for continuation of the pregnancy. So if you can control her blood pressure, if you can avoid the convulsions as well as the end organ damage, you can really pull through to a significant level till the baby becomes salvageable at least. And of course, meanwhile, you will prepare the baby for the delivery. So for lung maturity, you are giving antenatal steroids, and for the neuroprotection, you're giving magnesium sulfate. Now, suppose you are doing expectant management for this patient. When do you feel that there is a need for termination of this expectant management?
Termination may be
What
required.
investigations warrant termination of pregnancy? Dr. Shubhra.
Yes, ma'am. Ma'am, if the patient lands up into complication of severe preeclampsia, like she develops eclampsia, abruption, or maybe a renal failure, and if an ultrasound is suggestive of, as suggested, as it was very brilliantly discussed by P.K. Shah sir, Barcelona classification, if we have a reversed end diastolic flow or an absent end diastolic flow in
So, very rightly said. So, the indications will be maternal as well as fetal. Okay. So, development of complications, as you rightly said, the eclampsia, abruptio, HELP syndrome. That is one more. Yes. And acute renal failure, we have already discussed. On Doppler, reverse end diastolic flow or absent end diastolic flow. If these are the criteria present, then you have to terminate the, you have to terminate the expectant management and go for the active management. Of course, you have to prepare the baby in between. Now, anything else, when we are talking about the baby's outcome to be improved, we all of us know what steroids to be given. If somebody can quickly talk about the steroids, how much and which steroids?
We can give betamethasone or dexamethasone. Betamethasone at a dose of 12 milligram to be repeated after 24 hours, and dexamethasone at a dose of 6 milligram to be repeated every 12 hourly for 4 doses. And for neuroprotection, we give magnesium sulfate up to 32 weeks. Okay. We can give. So 4 gram loading dose and 1 gram per hour the maintenance dose.
Okay. So just to throw some light on the what is the Government of India guideline on the steroids, or whether you have something to be provided. See, FOXY and API, the IAP. Both the organizations say that you have to give antenatal steroid. May it be dexamethasone or betamethasone. It may be 12 milligram every 24 hours, maybe 6 milligram 6 hourly. It should be 24 milligram over 24 hours. At least it should give some protection to the baby. It should help in lung maturity. Government of India is providing dexamethasone as a vial to all the CHCs and PHCs. So Government of India is recommending dexamethasone. Now, why this is so? The betamethasone, the salt which is available in India is not the same which is used in the Western world, and that's a very reason dexamethasone is supposed to be more superior to the betamethasone, and I think that is in common use nowadays. So magnesium sulfate, we have already discussed that you will give initial bolus of 4 gram intravenously slowly as we give it for eclampsia, and 1 gram as infusion per hour. So for 500 ml of the pint, you will add 5 ampoules, that is 5 gram, and you will give 100 ml per hour. So that is how. But how long should you give this magnesium sulfate? How long? It has to be given for at least 24 hours.
4 hours.
Yes. And suppose the baby doesn't deliver within the 24 hours, then what will you do? Dr. Shubhra.
Ma'am, it should be given for 24 hours. Otherwise, we should stop the dose.
Correct. So there's no necessity to repeat the infusion. That is Same for steroids as well as for magnesium sulfate. Anything else you can do to improve the neonatal outcome? If you don't have the facilities for NICU and the higher management, it's better that you give the initial protective doses of antenatal steroids and magnesium sulfate and you transfer in utero to the higher center where you have the facilities for NICU. That is all. Which anesthesia? Suppose now you have rightly pointed out that yes, you have to go for emergency cesarean section. What type of anesthesia should be preferred and why? What type of anesthesia? What is the anesthesia we prefer?
Regional anesthesia is preferred in this case. Spinal and it can also be combined with epidural also. So these preeclamptic patients experience less hypotension with spinal anesthesia.
Correct.
And they are safer in these patients.
In fact, epidural is the best anesthesia and analgesia for all practical purposes. But yes, spinal anesthesia is preferred. General, that is regional anesthesia is preferred over the general anesthesia. Yes, of course, there are certain situations where you have the maternal condition very bad and the anesthetist need to have the entire control in his hand. Then definitely you have to prefer for general anesthesia. Dr. Deepali Verma.
Yes, ma'am. Dr. Deepali Verma, yes.
I would just ask you one difficulty for general anesthesia as an obstetrician, not
yes,
for the anesthetist.
As an obstetrician, ma'am, patient, because in general anesthesia, baby can have a little poor of gas for, and
but that is
also
acceptable because we know that because of the drugs, yes.
And uterus is also a little bit more relaxed, so we have to be prepared for PPH also. And also hypertensive response can be exaggerated during endotracheal intubation.
Correct. Basically, when you have given magnesium sulfate for either the impending eclampsia or the neonatal outcome, when you give general anesthesia, there is a drug interaction. There may be, the aggravating, there may be synergistic effect of all the drugs and it may be little difficult for the anesthetist as well. Secondly, for us, it can lead to a tonic PPH. So general anesthesia, the patient usually bleeds little more than the regional anesthesia. So very well done, all of you, Deepali and Jaya, Shubhra, Shraddha, everyone. We will go to the next case now. You have this 19-year-old primary gravida and she has 36 weeks, 19-year, mind well. 36 weeks of gestation, she has an uneventful antenatal course and she has been brought to you in utter state of consciousness. She gives, there is a history of convulsion from the relatives. When you examine, you find the blood pressure is 220 by 120, proteinuria is 3+ and she's not in labor. So, the moment you see this patient you receive in the emergency, what are the few things here to be done emergency? So, in other words, for a case of eclampsia, how do you go ahead about the management?
And first is the airway management.
Yes, Abhilasha Yadav. Abhilasha.
First of all, ma'am, we will call for some help and then maintain the ABC airway, breathing and circulation of this patient. We will catheterize this patient. We will put some IV access and then give magnesium sulfate.
So you will put 2 intracats, maybe 18 number or so. Yes. So for what you need 2 intracats?
For one, if the patient immediately collapses.
Yeah. So yeah, one for the maintenance intravenous infusion and the other for taking lab and giving magnesium sulfate. Okay. Okay. So what all things you want to do? You can just say it quickly.
We will give crystalloids, then we will give magnesium sulfate. Then this patient we will have to give labetalol in accelerating doses. Or if we required, then we will have to give IV infusion of labetalol also. Then we will go for termination of pregnancy.
If not also, we have to give intravenous labetalol because 220 by 120.
Yes.
So you have 2 complications, the hypertensive crisis as well as convulsions, eclampsia. So because it's not the only thing, eclampsia, such high blood pressure can lead to intracranial hemorrhage, hepatic rupture, and so many other complications. Even the pulmonary edema can occur. So our aim should be to bring down the blood pressure effectively in the safe range. So what do you feel is the safe range? To what level at least we should bring it down?
140 by 90 is safe, but
From
will
220 to 120, do you want to
but
bring it
220
to
by 120 will gradually
to the 150, 100, slowly. Okay, not very significantly, drastically. Okay, so the principles of care, basically the acute management. You have to take her on the eclampsia bed, preferably give her left lateral, do suction if she has frothing, put in airway to avoid the tongue bite and to make the airway patent, provide oxygen supplementation if she is breathing, seizure prophylaxis, as you have already said, fluid management is very important here. Antihypertensives, we have said, intravenous labetalol, intravenous magnesium sulfate, we have already done, and then you send the investigation and wait for the results, and then you manage and decide about the further management. Now, what are the different regimes for magnesium sulfate?
for magnesium sulfate, we will give
magnesium sulfate could be given in a Pritchard regimen, Zuspan and Sebai regimen. Pritchard is the one which we discussed already. The initial 14 grams of loading dose followed by 5 grams every 4 hourly maintenance dose intramuscular to be given for 24 hours after the delivery or after the last fit, whichever is later. The second is the Zuspan regimen. This is the same as the one which we are giving for neuroprotection. That is 4 grams initial IV dose followed by 1 gram per hour infusion. Another one is the Sebai regimen, which is 6 grams in 100 ml and given slowly, followed by 2 to 3 grams. But this one is not very much in use because it leads to slightly higher levels of magnesium sulfate. So the one which we frequently are using is the Pritchard regime because it is easy to monitor. Zuspan regime requires a strict monitoring of the dosage rate, should not exceed 1 gram, and it requires proper infusion pumps for that. Preferably, we are in our center, we are more going for the Pritchard regime unless we have additional neuroprotection in mind.
Perfect. So, Dr. Mohita, you have given her magnesium sulfate and you are monitoring her properly. So, Dr. Jaya, you see her convulsing once again within first 15 minutes. What do you do?
Ma'am, these patients have some time for the drug to be have a proper effect. So we can wait for 10 to 15 minutes.
Yes.
And if patient is obese or we say BMI is very high, then we can give 2 gram more, 20%.
So wait for 15 to 20 minutes. That is a message. So if she, now suppose you find this patient who has already received the therapeutic loading dose of magnesium sulfate, she convulses after half an hour again. Now what will you do?
Then we have to search for another cause of convulsions in this patient.
Immediately. She is well-oriented, conscious, no neurological deficit. So if she convulses after 15 to 20 minutes, maybe you repeat one more, that is 2 gram intravenous magnesium sulfate. That is the time. So initially you wait for 20 minutes. If she convulses within first 10 to 15 minutes, no worries. You can wait for some time, just manage the convulsion. If she convulses after 20 minutes, then you have to repeat 2 gram again intravenously. Suppose this patient, in spite of the repeat dose, also keeps on convulsing. Now you tell me, what do you suspect? Rather, what are your areas of concern? What are the pointers for neurological involvement and what investigation you ask for? Dr. Deepali, this is a question for you.
Yes, ma'am. Actually, repeated convulsions and severe neurological manifestations such as visual disturbances or patient becomes altered delirium or unconscious, we have to go for quick imaging. Because they can also point out some pathologies like obviously cerebral edema will be there, some intracranial hemorrhage can also be seen, pericapillary hemorrhages, especially in occipital, parietal lobes and also in frontal areas.
Okay. So in addition to repeated convulsions, what are the other neurological pointers that can guide you that maybe this patient has suffered some intracranial insult? What are the other pointers?
Yes, ma'am. Visual, blurring of vision, and also the...
That is there even for impinging eclampsia and eclampsia. Yes.
Yes, yes, ma'am.
What else?
Altered sensorium, like
Yes.
unconscious.
Yes. Yes. Altered sensorium, which is not corresponding, usually you have the post-ictal phase and she will be awake after some time. So if you find the altered sensorium, if you find some focal neurological deficit, and if she's getting repeated convulsions, that is status eclampticus, then of course you have to suspect that she has suffered some intracranial insult, and that's the reason you need to invite the neurophysician, go for CT scan, and all these things you have to take care. So we have already covered this: recurrent seizures, focal neurological deficit, very poor unresponsive general condition. Do we have NM, sir? So do we have, can we see Dr. Narendra Malhotra, sir, here to have some comments from him? Okay, so we will have it when sir joins once again. We have this last case now, Dr. Shubhra Agrawal. So this is a very severe problem, quite rare, but yes, you do have to face. There is a surprising fact here. So let us discuss the case here now. Dr. Shubhra, this is a case to be discussed for you. You have this 35-year-old primate with 33 weeks of pregnancy, and she is diagnosed as hypertensive at 28 weeks with blood pressure of 140/90. Proteinuria only 1+ to 2+. She was on tablet labetalol, well controlled. pH profile was normal. Ultrasound at 32 weeks was also okay. So cephalic presentation, AFI 12, birth weight 1.2 kg. Antenatal steroids were given at 30 weeks. Patient started suddenly complaining of severe headache since last 3 days and not relieved by any painkiller. Also, she's complaining of loss of vision, nauseating feeling. What is your diagnosis, and what will you do as management after you are hospitalized naturally?
Ma'am, these are the warning signs which we usually explain to a patient of gestational hypertension: loss of vision, nauseating feel, or an epigastric pain. So these are the signs.
Severe headache,
or edema, unexplained edema, physiological, not relieved on getting up in the morning. So I'll advise her urgent admission and would go for a blood profile, PIH profile, that is CBC, LFT, KFT for her, and a urine dipstick, which has been done previously, which was suggestive of 1+ or 2+. I may increase her antihypertensive dose, which is 100 mg TDS, to control her BP. And since she is also complaining of headache and blurring of vision, not controlled.
Dr. Shubhra, see, basically she was on tablet labetalol. Yes. In spite of all that, with well-controlled blood pressure, she developed these symptoms.
Yes.
So it is not severe hypertension and associated alarming symptoms, right?
Yes.
When her blood pressure was 150/100, and you increase the dosage to 100 mg 3 times a day.
Yes.
Okay. In spite of that, her headache and blindness, loss of vision continued. Now what will you do? How will you proceed?
Ma'am, advise her to go for an MRI as suggested in the slide, and maybe she is a case of TRESS if it is suggestive of loss of vision, where we can get a attenuation of the white matter in MRI. So that is what I can advise to this patient. And obviously a prophylactic magnesium sulfate has to be given to this patient to prevent landing
for this case, it was not prophylactic. See what the history says: while shifting for MRI, she convulsed on the way. So it is a therapeutic magnesium sulfate. So she is a case of eclampsia as well.
Yes.
Okay. So you just thought that it was alarming symptom that she had, and she convulsed. So you thought it's a purely a case of eclampsia. From this history, what we gather, it is a case of eclampsia. So suddenly, because she worsened, naturally we have to take care of the baby. So she was taken up for, fetal heart was confirmed and she was taken up for emergency cesarean section. Urgent MRI opinion was asked that. MRI says that bilateral parieto-occipital lobe subcortical edema, low density areas of white matter over posterior lobe. So now your diagnosis is revised to posterior reversible encephalopathy syndrome. Now, tell me, how do we manage this case?
Ma'am, in this case, we have managed it already. Like, we have done our emergency cesarean section, and as soon as we remove the cause which is causing press, the condition is relieved within 2 to 3 days. The patient may have a revived vision if we deliver the baby and remove the etiology behind press.
Okay.
So termination is the solution for this patient.
Yes. So that is what I wanted to tell you, that it is miraculous recovery from press. It is very threatening, you can say life-threatening complication we feel, but the moment you manage the patient properly, you take care of the mother, you take care of the baby, you stabilize her by giving anticonvulsant, anti-hypertensive, and you just give her a supportive management. Press is totally reversible, and maybe within 5 to 7 days, the patient can have complete recovery. That is what the message is. But what precautions the obstetrician should take, any specific measures to be followed by the anesthetist, what measures to be taken if at all she has cerebral edema, all these things have to be taken into consideration, and timely and appropriate management and intervention has to be done. That is what the discussion here is, and the message only is it has to be timely and appropriate intervention with proper supportive therapy. So press is a dreaded complication, but it is having complete recovery if managed well. So with this, I think, see, you can see here, there is no neurological manifestation after 7 days. Whatever edema the white matter has, it has completely regressed. So as we have already said, that prediction, prevention, and preparedness is the key to success in areas where dietary calcium intake is low. So we have already said that prediction, your history, family, medical history, history of previous pregnancy, all these things should be taken into consideration. The patient has to be categorized as having a high risk factor, and we are supposed to avoid the aggravating factors. If at all we predict that she is prone for development of hypertensive disorders of pregnancy, putting her on low dose aspirin, which nowadays accepted to be aspirin 150 milligram right from early pregnancy, and high dose calcium vitamin D is supposed to be very, very protective. It has to be initiated during early pregnancy itself. Bed rest absolutely has no role. In fact, it can be detrimental to the woman's health. Dietary salt restriction, not no salt. Previously, people used to say no salt or avoid salt. So that is a wrong policy. The patient can in fact land up with hyponatremia, which can still be detrimental to her health. The use of corticosteroids, as we have already said, that was for the neonatal prognosis, but here use of corticosteroids for the specific purpose of treating HELLP syndrome is not recommended. There is no evidence, though people are empirically using it. Antihypertensives, though we have various opinions by various organizations, preferably 140-90 millimeter of mercury or 30 millimeter of mercury rise above the baseline for systolic, and 15 millimeter of mercury rise above the baseline for diastolic. That is what should be the cutoff limit for starting the antihypertensive. To achieve the good hypertensive control should be the aim, and to take the pregnancy till salvageability, minimizing the complication, rather avoiding the complications of hypertension, which are, as all of you have already said, so intracranial hemorrhage, pulmonary edema, hepatic rupture or hepatic failure, renal failure, DIC, HELP, all these complications can be avoided with effective antihypertensive therapy. Close vigilance monitoring is the key to success, and for this we have to make sure that we have to categorize this patient and keep a watch right from the beginning. So hypertensive disorders of pregnancy, as we have already said, that is it is one of the 3 major causes of deaths of women. I can see Dr. Namrata here, and hi Dr. Namrata. Hello, Dr. Namrata. So, welcome to this program. I think we are almost finishing. So, the message here is prediction, prevention, and preparedness is the key to success for this dreaded complication. And wonderful inputs from all of you. Thank you, all of you, once again. All the presidents and secretaries of the Agra, Aligarh. I could not see Dr. Sushma Gupta. Yeah, so maybe a few people are busy in emergencies. Whosoever is here, once again, I thank all the president secretaries, all my wonderful panelists, and the quality audience we have it here. Thank you so much, Dr. Niharika and Sehla, for wonderfully managing the show. Thank you so much. And over to you, Niharika.
Thank you so much, Sneha ma'am. What a wonderful, informative panel discussion and right on point with great take-home messages. And now we have come to our end of today's webinar, and I hope all of you have enjoyed it. I invite Dr. Namrata to give the official vote of thanks.
Namaskar. Sorry, I just came from OT, ma'am. I missed most of your panel, but I'm sure, as always, it was incredible. It must have been incredible. I did attend Dr. Shah, the earlier lectures, and I'm so very thankful. So first of all, to Dr. Sneha, ma'am. Thank you, ma'am, for involving me in such an informative
pleasure, dear. Pleasure.
Thank you, ma'am. And I thank all the chief guests, Dr. Archana Verma, ma'am, Jadeep, ma'am, Evergreens, Naren, sir. Thank you, sir. You're always there for us, sir. And our esteemed speakers, our learned panelists. And last but not the least, our jack of all trades, Niharika and Shela. Thank you, girls. You're always so energetic, and you're always, yes, they deserve 3 chairs. And I thank you all for a very, very, very informative evening. Thank you, Sneha ma'am. Thank you, AMOGS, for involving Aligarh Obs and Gynae Society in your academics.
Thank you so much, my dear.
Thank you.
Thank you, everyone.